Just one clarification. This is going live. So there'll be participants.
Yes, sir.
Their questions will come in the chat box, or will Dr. Patil ask them the questions?
Sir, I have the link of a question, separate link. So I will going to, correspond with the audience.
All right. So you'll correspond with them and you'll ask the questions, isn't it?
Yes, yeah.
Make it simple, something that I can answer.
Sir, you can answer all the questions that they're going to ask.
Thank you so much.
I know, because I have not met you when during the MBBS day, but I was aware. Yeah. And also we also had one meeting with the Entron team, I think 3-4 years back, before the Corona. On the PPI only, advisory board meeting. So
all right.
You were the part of the meeting. That was the first interaction with you.
Oh.
Then I also heard you, sir, in Marian National Conference, ISGCon. I always part of the ISGCon the last 8 years.
All right.
I was great with you.
We have met there.
Yes.
Let's try that. It's 4 o'clock already, isn't it?
Yeah. Anil?
Yes, sir. We can go. Yes.
Shall I start?
Just a minute. In a minute.
Dinesh,
Hello?
from your side, some noise is coming.
Actually, the construction going on the upper floor.
Yeah.
So
Okay. Yes, sir. We can start. Pratik, we can go live.
shall I?
Yes, sir. Session has started. Yes, sir. Session has started.
Good evening, dear doctor. I am Dr. Dinesh Patil. Welcome you all on behalf of Alembic Pharmaceutical Limited for this today's scientific webinar. The concept of this program is to discuss the clinical issues faced by the clinician in their day-to-day office practices. Today, we have our expert in subject, Dr. Philip Abraham, sir. Presently, sir is a consultant gastroenterologist at PD Hinduja Hospital, Mumbai. Sir also has a retired professor and head department of gastroenterology, KM Hospital, Mumbai. As a gastroenterologist, sir has achieved significant achievement through his clinical career, like Lifetime Achievement Award for contribution to gastroenterology in India by Indian Society of Gastroenterology 2016. Lifetime Achievement Award for contribution to clinical research in India by Indian Society of Clinical Research in 2020. Sir was also the president for Indian Society of Gastroenterology 2002 to 2003 and Indian Motility and Functional Diseases Association from 2012 to 2016. Sir also performed a role as editor in the Indian Journal of Gastroenterology from 96 to 2006. And he also was a editorial board member of World Journal of Gastroenterology, Journal of Gastroenterology and Hepatology. Sir, also a reviewer for the various scientific journal across the national as well as international journals. And he also has a publication approximately 100, more than 100 index articles. Today, sir will be going to deliver his talk on the topic of dyspepsia management. Now I request sir to start the presentation. Over to you, sir.
Thank you, Dr. Patil. That was a wonderful introduction by you. I humbly accept your introduction, and we'll move forward with today's topic. Today's subject, as we know, is a clinical subject. When we talk about dyspepsia, our entire discussion will be clinical based about how to approach a patient with dyspepsia, how to take it forward with investigations and management. So can I start my slide sharing? Are we on? Are the slides visible?
Yes, sir. The slides are visible. So you can just maximize this.
Sure, it is maximized now.
Okay.
Yeah. Thank you very much again, Dr. Patil. Let's move on with the talk now. The focus now is on the management of dyspepsia. We'll first go through the introduction about what is dyspepsia, what investigations and when to do for it, and how to go about with the management of this condition. Very simple clinical subject for us, something that we face. Maybe 25 to 50% of the patients that we see in our clinical practice have dyspepsia as one of their major symptoms, if not their presenting symptoms. So when a patient comes to us saying dyspepsia, obviously they don't use that word, but they use the word indigestion. Khana pachan nahi hota is what they tell us. And it is up to us as clinicians to make a distinction about the origin of this symptom that these patients come with. For them, indigestion means their food is not getting digested. We would then divide it based on the symptoms as those due to gastroduodenal dysfunction versus the actual process of digestion. With digestion itself, we talk about the chemical process of digestion and the onward movement of food, because all of these can be clubbed together by the patient as indigestion, and which is a rough equivalent of what we call dyspepsia. So today we're going to focus only on the gastroduodenal causes of dyspepsia. The prevalence of symptoms attributed to the gastroduodenal function is about 20% of the world population, varies from country to country, obviously, also varies on the definition and what terms the patient uses to describe his symptoms. A majority of those who come to us saying khana pachan nahi hota hai or indigestion do not have an organic cause. I would think about 60, 70 or even more, 80% of patients would have no organic cause. So it's very important for us to also know this entity of what we call functional dyspepsia. So before we start the discussion, let's go to what is the definition of dyspepsia. Many definitions, many authors, many societies giving us guidelines. But one of the simplest ones I found was this by the ACG and the CAG together, where they said, and this was just 4 or 5 years ago, where they said that dyspepsia requires predominant epigastric pain lasting for at least 1 month. We're talking about chronic dyspepsia. We're not talking about acute dyspepsia. So predominant epigastric pain. And as we go to the Rome Foundation definition, we'll find that this is not always the case. Of course, the Rome Foundation has evolved over 20 years or more, but this is the simplest definition that I found. Predominant, that's the word, predominant epigastric pain. And then they say that this may be associated with other GI symptoms, upper GI symptoms, such as epigastric fullness, nausea, vomiting, heartburn, but provided pain is their predominant symptom. Beyond this, then we have a classification into functional dyspepsia, where we say these are patients who have dyspeptic symptoms, but in whom endoscopy and related investigations have found no organic pathology that explains the patient's symptoms. So to me, this is the simplest definition that we can have of dyspepsia. Predominant upper abdominal pain associated with several others. So we distinguish gastroduodenal from small intestine and the rest of the organs, associated with a lot of other upper GI symptoms. When we go further to the Rome 4 Foundation, Rome 4 definition of dyspepsia is much more detailed, because these definitions are more commonly used for research rather than for clinical practice. So they have given a separate guideline for clinical practice, but for research, Rome 4 has defined dyspepsia as any combination of 4 symptoms, that is postprandial fullness, early satiety, epigastric pain, and epigastric burning. We can see from this definition itself that the first 2 are generally clumped together and the next 2 are clumped together. Pain and burning as one set of symptoms, early satiety and fullness as the other set of symptoms. But they have put a timeline to it as well. They've said this onset should be at least 6 months versus 1 month for the ACG and CAG, 6 months in advance, with symptoms occurring at least 3 times a week in the last 3 months. So very strict definitions, very strict guidelines of criteria for the diagnosis of chronic dyspepsia. They then go on to divide chronic dyspepsia into 2 major groups, the functional group, which forms the majority of our patients, and the secondary dyspepsia group. And the functional group is again divided, as the definition shows, into the epigastric pain syndrome and the postprandial distress syndrome. The first 2 symptoms versus this next 2 symptoms. Secondary, they have now made a subset of patients who are called H. pylori associated dyspepsia and the other causes of secondary dyspepsia, and we'll come to that later. So broadly, Rome 4 has divided it into functional and secondary. Secondary as secondary to H. pylori infections and secondary to other causes, and primary or functional into 2 subclasses. So secondary dyspepsia, as all of us would understand, is organic, systemic, or metabolic causes that can be identified by traditional diagnostic procedures. And eliminating or improving that disease will resolve the patient's dyspeptic symptoms. So you have a cause, and the proof of the pudding lies in treating that cause and elimination of the symptoms. So examples of these are peptic ulcer disease, malignancies, pancreatobiliary diseases, endocrine disease, and medicinal use or medication use. In the West, opium is, of course, a major contributor. We don't have that as a major contributor. Here, as I said earlier, they have a subset of patients who are called Helicobacter associated dyspepsia. Now, here we have a difference of opinion with the West, because H. pylori infection is so common in India that to attribute symptoms to H. pylori is a stretch. So we do not in clinical practice take H. pylori as a separate subset. We take it, in fact, as part of those who have been investigated for functional dyspepsia. But Rome 4, secondary dyspepsia, one subset is the H. pylori dyspepsia. Functional dyspepsia, again, is those in whom there is no explanation based on organic conditions for the dyspepsia, and in whom, at the bottom, you'll find there's no evidence of structural disease, including at upper endoscopy, that can explain the symptoms. And the diagnostic criteria are one of the two, two of the four, that is, one or more of the following, that is, bothersome postprandial fullness, early satiation, epigastric pain, and epigastric burning. And based on these diagnostic criteria, they have divided functional dyspepsia into two: epigastric pain syndrome and postprandial distress syndrome. If you go back in history, we realize that these were conditions earlier called ulcer-like and dysmotility-like. So with each evolution of the Rome criteria, we have new terminology coming up, and we'll see more examples of that as we go along. So epigastric pain syndrome includes at least one of the following for at least 1 day a week. That is bothersome epigastric pain, and they define bothersome as severe enough to impact on usual activities, or bothersome epigastric burning, again, severe enough to impact on usual activities. Now, the difference between this and the next one is that here, it may be induced or relieved by a meal or fasting, and may be accompanied by other symptoms, upper GI symptoms, but they have excluded one condition. And this is important for us to realize, that the gut is not divided functionally into various parts. It is divided anatomically into upper, middle, and lower, or upper GI, lower GI, but functionally, it is all one continuous system. So when you have a patient with constipation, that is a motility problem, he'll also obviously have upper GI symptoms, because the entire system to him is blocked. So any symptom that is relieved by defecation is not included in the definition of functional dyspepsia. And you can see this exclusion even in the second group, that is the postprandial distress syndrome. Here, as the name itself suggests, we're talking about meal-related. So this is postprandial fullness, severe enough to impact on usual activity, and postprandial early satiation, severe enough to prevent a person from finishing his regular meal. So these are those who together form the postprandial distress syndrome. Again, they may have associated symptoms, but like in the first group, exclusion are those who are relieved by defecation. So to go back, we have the secondary dyspepsia, including Helicobacter, functional dyspepsia divided into EPS and PDS. Just one slide about the pathophysiology of functional dyspepsia, because now we're going to take these two conditions separately, that is secondary and functional dyspepsia. Functional dyspepsia, I wish we knew the answer of what causes that. There's so many contributing factors that go into it, including decreased accommodation, abdominal gastric content distribution, over-distended stomachs, gastroesophageal reflux, gastric inflammation, duodenal inflammation. But to me, the one that is most important is what we call visceral hypersensitivity. Why is this important? Why is visceral hypersensitivity so important? Because ultimately, as we can see, Rome 4, I'm sorry, this is not moving forward. Yeah. Rome 4 has now decided to call functional disorders as disorders of gut-brain interaction. That means the term functional in the minds of most practitioners means there's a mental part to it. But now we know that the primary organ that is at dysfunction is the gut. So gut-brain dysfunction or gut-brain interaction disorder is what functional dyspepsia are now being called. So to me, that means that visceral hypersensitivity is the most important component of all the other contributory factors that we are talking about. When we look at who are the patients with dyspepsia whom we need to investigate, we obviously look at alarm features. Again, maybe varying from time to time or from place to place. One of those is those in whom there is a late onset symptoms. Now that late is where the definition problem comes. In some countries it's taken at 45, in some countries as 50, and in some countries as 60. We don't have a cutoff age. But the older the patient, the shorter the duration of symptoms, more the likely that there is an alarm feature there. The others are unintentional weight loss. Dysphagia in a patient who talks about heartburn, odynophagia in a patient who talks about heartburn, iron deficiency anemia that cannot be explained by other means or with or without GI bleeding, Persistent vomiting, not a feature of dyspepsia. Obviously, on examination, palpable mass or lymphadenopathy, and if there is a family history of upper GI cancers. So if any of these exists, then these are patients who must be investigated. In clinical practice, do we look at only these? Yes, we should. But in clinical practice, even in the absence of these, many patients undergo endoscopy, which is not what is supported by guidelines, but there are many components to it, and we're not going into details of that. Coming down now to the management of dyspepsia, let's take a look at what the American College of Gastroenterology and the Canadian Association of Gastroenterology say. If a patient comes to us with an adult patient comes to us, if he is more than 60 years of age, he must undergo investigation for secondary causes of dyspepsia. If he is less than 60 years of age, what they say is investigate him first for H. pylori, test him, and treat him if he turns positive. Now, there's a difference of opinion, like I said right in the beginning, between India and these countries, in that Helicobacter is so common in India that if everybody who came with dyspepsia were investigated, we would find this organism maybe in 60 to 80% of individuals. Are we going to treat all of them with antibiotics? And we'll come to how complex the antibiotic regimen is as we go on. Are we going to treat all of them? Or is there a selective group that we would treat? So we in India, as clinicians, we practice that if there is no endoscopic or alarm feature and no need for investigations, or has been investigated and is negative, then we look at other factors, among them Helicobacter. So it's not that if the person is less than 60, we would go straight for H. pylori investigation and treatment, but that's a Western guideline. So before we go on to functional dyspepsia, which is our focus today, let's talk about the management of secondary dyspepsia, because we just talked about dyspepsia management first being ruling out secondary dyspepsia. So if you look at secondary dyspepsia, of course, these are patients in whom on history and physical examination, there are some alarm features. If there are, and I listed the alarm features earlier, if there are, these patients must undergo endoscopy with or without biopsy. The advantage of biopsy is that you can also look for gastritis, you can look for H. pylori infection, and of course, if there is a tumor or any area that's suspect, we could biopsy them. If based on endoscopy and or biopsy, we get the diagnosis, that's it. We follow it up in that direction. If we don't, but the patient still has alarm features, if the endoscopy is normal, we'll go for the other diagnostic tests. And based on that, if we find some abnormality, for example, pancreaticobiliary disease, then we'll follow that. So if either an abnormality is found on endoscopy or on other investigations that can explain the patient's symptoms, these are patients who are then moved out of the group of dyspepsia and are managed for their primary condition. Come down now to Helicobacter. First, we talk about the diagnosis and then the management, because after we've ruled out secondary causes for the dyspepsia or causes of secondary etiologies for the dyspepsia, the next recommendation, as per the Western guidelines, is to look for Helicobacter pylori. Like I said earlier, let me clarify once again, we don't necessarily follow this. We do not do a serology test or a stool test or a urea breath test unless there are clinical suspicion. What happens in practice is a different story, but we talk about as an academic center what we should do. If there is a reason to suspect Helicobacter pylori infection, a recent exposure, a recent onset of symptoms, or a family history of H. pylori infection leading to dyspepsia, then we would proceed with investigating these patients for this infection. When an endoscopy is not indicated, we have non-invasive tests. Serology, unfortunately, is not a reliable test. And this is a fact that needs to be emphasized because these tests are available in the market. So we find a lot of physicians asking for IgG antibody to Helicobacter and then saying you got this infection and treating it. Remember that the IgG serology remains positive for months, maybe even longer after an infection. So having this serology positive does not mean that this is the cause of the patient's dyspepsia. So in general, except for epidemiological studies, we do not look for serology in H. pylori infection. What we do is either the stool antigen test or in centers that have the urea breath test machine with or without isotopes, we would use that as a first line investigation. These are non-invasive tests where there's no indication for an endoscopy. In those who have other indications for endoscopy, we would then do an endoscopic biopsy and we would do a rapid urease test, histology, molecular tests for research purposes, and where facility for culture is available, you also do a culture and susceptibility test. Why am I saying centers with culture availability? Because this is not an organism that is easy to culture. It's quite a fastidious organism. So to get a culture positive, you need to have a dedicated lab that's looking for this infection, looking for this organism, so that you could isolate it and look for culture. So obviously in clinical practice or in most institutions, this is not done. In most institutions, it is endoscopy with urea breath test, endoscopy with rapid urease test, or no endoscopy, then urea breath test or stool antigen test. So once we've established the diagnosis, once again, remember that most commercial H. pylori kits available in India do not have proven records. So blindly prescribing it, like it happens so often in management, or even prescribing it after the patient tests positive, is just a shot in the dark. If you look at the recommendations by the Maastricht 4 group or a Maastricht 4 Florence recommendations, it says that H. pylori antibiotic resistance is increasing in most parts of the world. And when we talk about antibiotic resistance, India stands somewhere on top. So it says that where there is more than 15% clarithromycin resistance, as happens in India, then we should not be using a PPI clarithromycin containing triple regimen without prior susceptibility testing. And we should use either a bismuth quadruple or a non-bismuth quadruple concomitant therapy if these regions have more than 15% clarithromycin resistance. In areas with clarithromycin and metronidazole resistance, like India, then bismuth quadruple therapy is recommended. And unless you have evidence to show that 10-day therapy works, the recommendation is to give for 14 days. So you can see that most of the commercially available kits in India are not appropriately tested for use in India. They're just blind 3-drug therapies given with blind combinations of antibiotics. But in an academic center or in a research center, we should be following these guidelines because we have high resistance rates for both metronidazole, for that matter, for both the imidazoles in common use, as well as for clarithromycin. So if I have to summarize that, where there's a low metronidazole resistance, you can use a triple drug therapy. When there is a low dual metronidazole and clarithromycin therapy, resistance, you could use bismuth-based or non-bismuth-based quadruple therapy. But when we have a high dual resistance, that is clarithromycin and metronidazole, as we suspect is happening in India, then we should be using bismuth-containing quadruple therapy, preferably for 14 days. So these are important points that we should talk about when we decide that this patient's Helicobacter needs treatment. And that decision is different from how they make it in the West. So here we've looked at the secondary dyspepsias, we've looked at Helicobacter-associated dyspepsia. Now we come to functional dyspepsia. All of us give these lines of advice to our patients. These are common sense advices. There is no systemic study, and there will probably never be a systematic study in future to establish the value of these measures. But that's because evidence-based medicine cannot be followed in every aspect of life. You don't have to tell a patient, for example, that you need evidence that you have to eat through the mouth. So evidence has its limits. Common sense tells us that the first thing we should do for these patients, especially when we're talking about gut-brain interaction, is reassure the patient. And how do we reassure him? To tell him that functional dyspepsia never killed anyone. It can cause discomfort, it can cause harassment to the patient, it can trouble the patient, but it is not a life-threatening condition. That's the first reassurance, because as time goes on and there's no cure for this condition, patients become increasingly frustrated. The second thing we have to tell them is, look, this is something that will persist. It will keep troubling you, but don't worry about it. We can always manage it with some medication. So the second thing is about educating him to some level about how these symptoms are caused. I have seen that in clinical practice to give some comfort to the patients when they know that the doctor has an explanation for what is happening to them. So educate them, and most of our patients will understand. The third step is lifestyle modifications or dietary modifications. Smaller meals. What does it mean? I tell our patients, however fine the meal is, however tasty it is, never eat to the fullest. Try and restrict meals with high fat content. And if you take fat content, be prepared for the discomfort that comes for it. restrict the use of tea, coffee, or carbonated drinks. In India, carbonated drinks is not a big deal, but we've seen in the upper strata of society that in fact it is a big deal. But tea, coffee, we allow them up to 2 cups a day. So fat restriction, spice restriction, not to lie down for at least 2 hours after any meal, and of course, tobacco use. You notice in all this that alcohol is not mentioned because the evidence for alcohol as a cause of dyspepsia is not very strong. In other words, there is a moderate limit to alcohol. There is a safe limit to alcohol even in patients with dyspepsia. But tobacco is different. There is no safe limit for tobacco in any form. Smoking is a major form, but in no form is there a safe limit for tobacco use in dyspepsia. So that should be total abstinence. NSAIDs, unless there's a strong indication to take it, but generally we tell our patients, take paracetamol or acetaminophen if you have to. But if you have to take an NSAID or if a doctor ever prescribes you, and we mention the drugs for them, we tell them that if a doctor ever prescribes these to you, please tell him or her that I have these symptoms as well. So now let's fall back once again on the ACG and CAG guidelines. We first talked about an adult with dyspepsia where we talked about secondary causes and Helicobacter. Now we talk about the patients in whom these two have been kept aside, and these are now diagnosed as patients with functional dyspepsia. There, as I mentioned earlier, they look at the group with Helicobacter positive and eradicate that. We don't always do that, and there are clinical reasons for it. But when it comes to the other side, the right side of our chart, where Helicobacter is negative, the first line treatment recommended by them is PPI with or without a prokinetic, which for them becomes a third line, but for us is the second line. In between this first and third line, they talk about tricyclic antidepressants, which for us will become the third line. So we're talking about PPI with or without prokinetic, and then if necessary, add a TCA. So if you look at the Asian guidelines, based on the symptoms, on the left side, you have the epigastric pain syndrome, where we talk about PPI with or without a prokinetic. And on the right side, we have the patients with PDS, postprandial distress syndrome, where we talk about prokinetic with or without a PPI. Once again, I have a difference of opinion here. I think PPI should be common to both the groups, and whether or not to add a prokinetic will depend on whether the person has dysmotility-like symptoms or not. So PPI common to both. And although this was the Asian recommendation earlier, not all of us would follow that. So getting back once again, the Rome 4 classification had divided functional dyspepsia into epigastric pain syndrome and postprandial distress syndrome, and the management differs entirely. Which brings us back to our first point. When a patient comes with dyspepsia, make sure that these symptoms are from the gastroduodenal center. Once you've localized it to the gastroduodenum, then look at what is his predominant symptom. Is it pain and burning, or is it bloat? Because your further management will depend on that. Now, as we go further, I'm going to quote extensively from this position paper on rational use of prokinetic agents for disorders of the upper GI tract, which was published just recently, just a few weeks ago, by the Indian Society of Gastroenterology. So this is a task force or an expert group that published this position paper on rational use of prokinetics in upper GI conditions. So I'm going to quote from these as well as from the CAG and ACG guidelines. So this book had listed the prokinetic agents that have been approved in India. To an extent in India, we're very fortunate because almost every prokinetic agent available around the world is available in India. And we see how less fortunate our colleagues are in other countries. In the US, for example, many European drugs are not available. In Europe, some of the American drugs are not available. The US FDA has a policy saying that if we have one prokinetic, unless there's a strong indication to introduce a second one, we will not allow a second one. So while they have metoclopramide, they do not have domperidone. In India, it's a free-for-all. All the prokinetics that we can think of have come to India. Drugs like cisapride and tegaserod have been taken off because of Western reports of side effects of these drugs, something that we haven't seen much in India. But for some reason, these drugs were banned abroad, and so we followed suit. We banned them in India as well. But these are the prokinetic agents. I don't need to go into details because all of us know what's available in the market. Now, these prokinetic agents have different mechanisms of actions, and there we're focusing mainly on the 5-HT3, 5-HT4 receptors and the D2 receptors. So one group are those who have the 5A, or those who are the 5-HT4 agonists, like cisapride and mosapride. Now, of course, we have only mosapride with us. Levosulpiride has both 5-HT4 agonist action as well as D2 antagonist action. On the other side are the ones who have predominantly D2 with or without 5-HT3 mechanisms. So D2 antagonist or 5-HT3 antagonist is metoclopramide, and D2 antagonist is domperidone. We have other drugs also available in India, like acoshamide. Etopride, we know, is one of those most popular prokinetic agents in the market, which has both D2 as well as acetylcholinesterase inhibitor functions. Prucalopride, we know, is a drug that is used for constipation. We should also know that it has a prokinetic effect, so it has upper GI prokinetic actions as well. Among all these drugs that are listed there, the ones that we don't use frequently, or the one that we don't use frequently, is levosulpiride, because of his psychotropic effects as well as its effect on the prolactin. Metoclopramide, domperidone also to an extent have side effects, but that has not prevented us using domperidone probably as one of the most popular prokinetic agent. Metoclopramide, for some reason, mainly because of its extrapyramidal effect, has not found favor in recent years, although it was our darling about 20, 30 years ago. So these are all the prokinetic agents that are available in India. Here I have listed all of them and given a comparative table. Domperidone and etopride, and to an extent acoshamide, are the three drugs that we use in clinical practice. Do they cross the blood-brain barrier? Domperidone, yes, to an extent. Etopride, no. Acoshamide, also yes. But we must remember that although all of these are clubbed together as prokinetic agents, acoshamide stands a little aside in that it actually allows gastric relaxation or accommodation. It's an adaptive accommodation that acoshamide functions as. Domperidone and etopride, on the other side, have predominantly prokinetic, that means onward movement action with them. Like with most other combinations in the country, we have a host of FDCs, that's fixed drug combinations in India, with PPI and prokinetic agents. So here I've listed, and you can see from this list that every PPI available in India has a prokinetic or is with or without a prokinetic. So we have combinations of all the PPIs with all the prokinetics available in India. I'm not saying this is the right thing to do, but FDCs have become so popular that the most common prescriptions, especially among our physician colleagues, our surgical colleagues, is to prescribe prokinetics along with PPI as first-line treatment, irrespective of the patient's symptoms. That's not something that we would recommend at all. It's a tribute to the safety of these drugs that after these patients have used them for 5 years, 10 years, they still have no side effects. But that is unsupervised use. Under supervised use, we should always give only the drug that is indicated in that situation. So in my clinical practice, for example, I would start with a PPI prokinetic if the patient has the postprandial distress syndrome or has GERD. I would start with this, and once the patient is relieved of his symptoms, I would take off the prokinetic and then continue with the PPI. But that's only my personal choice. There's no recommendation to say that you should actually go down this hierarchy from a combination to a single drug. But for a person who needs both the drugs, I may use a combination, not necessarily as an FDC, and then over time take off the prokinetic so that there is no risk of long-term use from these drugs. And in my practice, I also bring down the PPI to the lowest effective dose, some things that we sometimes tend to forget in our clinical practice. And with the availability of double dose PPI also now, I am a little afraid for the future, because there is scope for misuse of these drugs in a double dose, where a person would do probably with a standard dose or even a low maintenance dose. So the availability of these high doses has made the use of lower doses as, redundant, not something that I would look forward to so favorably. So where do we use the prokinetic agents? Commonly, we use them in functional dyspepsia, the ones who have the postprandial distress syndrome, and East versus West. Most of the studies from the East Most of the countries in the East who have provided guidelines for the treatment of functional dyspepsia put prokinetics high up. Whereas in the West, it's put as third line, as we saw earlier. First PPI, then a tricyclic antidepressant, and then the prokinetic. Whereas Eastern guidelines and clinical practice in India is PPI, prokinetic, and then the TCA. So postprandial distress syndromes, I would use domperidone or etopride. Early satiety, because that's what ecoshimide does, gastric accommodation. So early satiety, the second type of postprandial distress syndrome, I would use ecoshimide. In irritable bowel syndrome, which is not part of our discussion today, for constipation particularly, prucalopride. I have brought it up here only because it's a prokinetic agent with upper GI benefits as well. In functional constipation, also prucalopride. In gastroesophageal reflux disease, where I know clinically that gastric emptying is a contributing factor to the GERD, I would use a prokinetic. So not all GERD requires a prokinetic, but those who have volume reflux or those who have gastric dysmotility as a component, bloating, early satiety, long-standing distress after a meal, these are the individuals in whom prokinetics may have a benefit. So I would combine that with the PPI in a subset of patients with GERD. Less commonly, because these are less common clinical indications, gastroparesis of any cause, intestinal pseudo-obstruction, or adynamic ileus are situations where we use the intravenous formulation as of prokinetics. One situation where we would never dream of using a prokinetic where there is any evidence of obstruction, either gastric outlet obstruction or small intestinal obstruction. Do we use TCAs at all in dyspepsia? Yes, there's strong evidence for that. Here's a systematic review that just came about 5 or 6 years ago, where they showed 3 trials that evaluated tricyclic antidepressant therapy, showed that they have a significant effect in reducing dyspeptic symptoms. So we use them in patients who either have a predominant depression, anxiety complex with them, or who are not responding to our first and second line treatment. But yes, TCAs do have a role in treatment of dyspepsia. So if I have to summarize and conclude everything that we talked about, I'm going to quote from these 2, dyspepsia management, the ISG position paper statements, as well as the ACG and CAG guidelines. The ISG position paper states that when delayed gastric emptying is found, or let's put it this way, let's look at the data first. Of those who have dyspepsia, 1/4 of them with functional dyspepsia have delayed gastric emptying. 1/3 have hypersensitivity to gastric distension, and about 40% have impaired gastric accommodation. So our use of prokinetics and which drug to put where will depend on which of these components is clinically identified in a patient who presents with functional dyspepsia. Acid suppression therapy is the traditional first line, which we talked about earlier. So PPI or H2RA is the first line of treatment for dyspepsia, justifiable in most of these patients, such as those with epigastric pain and in overlapping GERD. Why am I putting a cautionary clause to this? Where is the evidence that all patients with dyspepsia have a role for acid? We don't have that kind of evidence, strong evidence. But still, traditionally, we've used an H2RA or a PPI as first-line therapy. And prokinetics may be added as first-line therapy in those who have PDS or delayed gastric emptying, and as second-line or third-line treatment, that is after PPI and prokinetics, especially if the patient has a presence of psychological comorbidities in epigastric pain syndrome. So that's the ISG position paper. Finally, we come to dyspepsia management guidelines from the ACG and CAG, which is a Western perspective, of course, but they are saying that functional dyspepsia patients who are H. pylori positive should be prescribed therapy to treat the infection. Not something that we in India would agree with entirely, and the reasons I mentioned earlier. They also say that patients under the age of 60 should have first empiric PPI treatment if they are H. pylori negative or remain symptomatic after H. pylori eradication. Again, that if clause is not so easily accepted in India. Third, patients under the age of 60 not responding to PPI or H. pylori eradication should then be offered tricyclic antidepressants. Again, not the same as we would follow. We would use that as third-line treatment. Then they talk about functional dyspepsia not responding to PPI or to H. pylori eradication or to TCAs should then be offered prokinetics. Like I said, in Asia, we would take this higher. We would talk about PPI, with or without prokinetics, and then TCA. So that's a significant difference between practice in the West versus practice in Asian countries. And functional dyspepsia patients not responding to any of our drugs should be offered psychological therapies. Now, here there's one component missing in India, and that is relaxation techniques like yoga, for example, or TM, or non-pharmacological measures to reassure the patient, to educate them. So to me, this comes right on top. The use of psychotropic therapies, yes, would come at the bottom. But offering them the option of relaxation techniques, of understanding the pathophysiology would come higher up. The use of drugs as psychotropic agents would, as they said, come lower down. So with this, I think I have given a fair idea of how we would approach patients with dyspepsia, secondary, followed by functional. Somewhere in between comes H. pylori in the West. For us, H. pylori remains a gray area only because we don't have sufficient data. What to do for secondary, we've talked about. What to do for functional will depend on the age of the patient and the predominant symptom of the patient, whether it is burning or pain, or it is fullness or early satiety. So our approach will depend entirely on our clinical analysis, localizing these symptoms to the gastroduodenum, and then analyzing the symptoms to see which patient will benefit from which approach. So, like the cliche says, there's no one size fits all. It's extremely important in gastroenterology, as in other fields, to analyze the patient's symptoms, to personalize the treatment, and to tailor the drugs to the patient's symptom. Because particularly in this condition, we are not treating a disease to eradicate it or to cure it. We are treating a symptom complex to give the patient relief, knowing that that's all he needs by way of treatment. Thank you so much for listening.
Thank you, sir. Now I request all delegates to post your question in the link which is provided to you. Sir, I also received a few questions, so we'll start with those first. There is a question from Dr. Kamil. He's asking what is the differentiation point between the GERD and dyspepsia?
Okay, now GERD, it's a very good question, because even the Rome Foundation has been haggling with this question. When a patient has only esophageal symptoms, whether it is heartburn or regurgitation or non-cardiac chest pain, or a combination of these, we would call it GERD. Whereas patients with dyspepsia will have symptoms in the gastroduodenal tract along with esophageal symptoms. Then reflux symptoms become part of dyspepsia. So if it's only reflux symptoms, it's GERD. If reflux symptoms are part of dyspeptic symptoms, it is part of functional dyspepsia.
How long we can treat these patients? Basically, that's the duration for the treatment of PPIs in dyspeptic patients.
So we're getting into a field that I didn't want to get into, and that is the side effects from long-term PPI therapy. We know about the side effects. We also know that irrespective of what theory tells us, in practice, many Indian patients get away with murder, if I can use that term, because we see that even when we prescribe B complex, we want to cover it with the PPI. So PPI is so irrationally used in India. The side benefit of that is it's a tribute to the safety of these drugs. So long-term treatment generally does not give side effects, but we should be very aware of what are these side effects, particularly in patients who are debilitated, patients who have pre-existing renal dysfunction or weak bones. We should be extra careful about prescribing a PPI. Those who are nutritionally compromised or those who are from unhygienic circumstances, yes, because PPI can interfere with nutrient absorption. It can also increase the susceptibility to infection. So bone disease, renal disease, compromised hygiene, compromised nutrition are 4 principles that we should follow in restricting the use of PPI. Having said that, for all patients with PPI, it's extremely important, like for all drugs, to choose the lowest effective dose for the shortest effective duration. So the treatment long-term with PPI is, as per the AGA guidelines, only for patients, for example, with GERD who may need it, or patients with Barrett's esophagus, or patients with neuroendocrine tumors, that is gastrin secreting, what's called the Zollinger-Ellison syndrome. These are only 3 or 4 indications where long-term treatment is approved. But in that, I would also want to add functional dyspepsia if the patient's symptoms are dependent on this. I must add a clause here that although the recommended dose, let's say for rabeprazole is 10 milligrams, we have clinical evidence to show, clinical practice to show that even if we give these drugs on alternate days, they're relieved. Because it takes 3 or 4 days after the drug is discontinued for the symptoms to come back. So it makes sense to give it alternate days. So the principle is the lowest effective dose for the shortest effective duration.
So there's one question from Dr. Vipul. He's asking how to manage the patient which is coming for the first time with the dyspeptic symptoms.
So like I said, the first thing to do is, of course, understand the patient's symptoms. Where does the patient have the symptoms and what are his symptoms? If the symptoms are all supradiaphragmatic, this is a patient with GERD. If the symptoms are gastroduodenal, then it is dyspepsia by our definition, although it doesn't correspond to the word indigestion that our patients use. So patients who talk about epigastric symptoms to the exclusion of supradiaphragmatic and lower abdominal symptoms are gastroduodenal symptoms. And once we've localized it to the stomach duodenum, then we look at pain and burning as one component, bloating and early satiety as another component. So that's the division of functional dyspepsia into EPS and PDS. Maybe both the groups will benefit to some extent from PPI.
So one kind of miscellaneous kind of a question asked by Dr. Dushyant. What is the role of a refrigerated food in causing a dyspepsia? Is there any role?
Of course, we don't have science to it, but it's common sense to know that any extremes of temperature, too cold or too hot, can precipitate symptoms. More so too hot than too cold. But I'm not aware of any science to say that too cold food is not good. We're not talking about preserved food. That's a different group. We're talking about cold as in refrigerated food. I'm not aware of it causing any dyspeptic symptoms. Heartburn, yes. Non-cardiac chest pain, yes, it can.
So we're done with the most of the question. Other questions are like repetitive. What is dyspepsia and role of PPI in dyspepsia? So all other questions are repetitive kind of questions. One question about the PPI use and pregnancy. So they're saying it used to role of PPI can be used in a pregnant female.
So in pregnancy, the principle, of course, is not to use a drug unless there is a strong indication for it. And if the patient has only intermittent dyspeptic symptoms, I would try to tide the patient over with just an antacid syrup. Of course, realizing fully well that 4 times a day of antacid syrup given for several weeks has its own side effects. So if it's an occasional symptom, and most of them land up with epigastric burning or more commonly heartburn as a consequence of pregnancy, if they can be controlled with the antacid syrups, nothing like it, I would still give an H2RA, although the evidence says that H2RA are not as effective for reflux as PPI. In fact, H2RA are not part of guidelines for treatment of heartburn, but I would still give them a chance with H2RA. Unfortunately, omeprazole was the first drug to be released among the PPI groups. So at that time, the US FDA had given a black box warning against the use of omeprazole in pregnancy. Now, this is in the face of clinical practice where a lot of people do give omeprazole, and we have evidence for safety of omeprazole in pregnancy, but not something that I would recommend at all. So my first line would be an antacid, second line would be an H2RA, and if I have to use a PPI for the shortest duration, particularly if possible after the first trimester, I would use a non-omeprazole, non-esomeprazole PPI.
Thank you, sir. We are done with the most of the questions. So, sir, on behalf of Alembic family, I would like to thanks, sir, for visiting and enlightening us with the knowledge. Today's lecture was full of knowledge and interesting things. So, I guess definitely it will going to help the clinical practitioner to do their practice in a better way. And in also addition, I would like to express my heartfelt gratitude to all the delegates who turn out in a great number today from squeezing out time from their busy schedule and grace the occasion. I would also like to thanks to the organizing committee, especially the entire marketing and sales team, for all necessary arrangement and successful conduction of the event. Thank you, sir. Thank you all.
Thank you very much, Dr. Patil, and a special thanks to our delegates as well.